Welcome back to another episode of Diabetic Foot Files LIMBWatch Edition. So today we are welcomed by one of the world's leading pioneers in limb preservation, Dr. David Armstrong, to his landmark research, including the University of Texas wound classification system and his groundbreaking work introducing the concept of diabetic foot remission. Dr. Armstrong has transformed the way we understand diabetic foot ulcers. Dr. Armstrong is a distinguished professor of surgery and neurological surgery with tenure at the University of Southern California. He also holds a Master's of Science in Tissue Repair and Wound Healing from the University of Wales College of Medicine and a PhD from the University of Manchester College of Medicine, where he was appointed the visiting professor of medicine. He is also the founder and co-director of the Southwestern Academic Limb Salvage Alliance. He also has produced more than 770, forgive me, peer-reviewed research papers in dozens of scholarly medical journals, as well as over 120 books and chapters. He is also the founding co-editor of the American Diabetes Association Clinical Care of Diabetic Foot, now in its fourth edition. And Dr. Armstrong is also the director of USC National Science Foundation funded Center to Stream Healthcare in Place, which places him at the nexus of the merger of consumer electronics, wearables, medical devices in effort to maximize hospital-free and activity-rich days. Dr. Armstrong also has been one of the first six international wound care ambassadors and is a recipient of numerous awards and degrees by universities and international medical associations and organizations, including the inaugural Georgetown Distinguished Award for Diabetic Limb Salvage. And in 2008, he also was the 25th, as well as the youngest ever elected to the Podiatric Medicine Hall of Fame. He also was the first surgeon to be appointed University Distinguished Outreach Professor at the University of Arizona, and he also was the first podiatric surgeon to be selected as president of faculty at Keck School of Medicine of USC. Furthermore, he was the first podiatric surgeon to become. I know it's a lot. Yeah, first podiatric surgeon to become the first member of the Society of Vascular Surgery and the first U.S. podiatric surgeon named Fellow of the Royal College of Surgeons, Glasgow. And in 2010, the youngest ever recipient of both the ADA Rogers Pacoro Award and 2023 recipient of the ISDF Carol Baker Award, the highest award in the given field. And Dr. Armstrong is the past chair scientific session for the ADA Foot Care Council and a past member of the National Board of Director of American Diabetes Association. He's also the co-founder of the International Diabetic Foot Conference, DFCON, which is amazing, the largest annual international symposium on the diabetic foot in the world. And he also is the founding president of the American Limb Preservation Society, which is a medical and surgical society dedicated to building interdisciplinary teams to eliminate the preventable amputation in the US and worldwide. So if you ever treated a diabetic foot ulcer or had one, you most likely have been influenced by Dr. Armstrong's research. So welcome, Dr. Armstrong, and forgive me, it was definitely a mouthful.
Oh my gosh, Gabby, thank you so much. I was like crazy. You could only be disappointed after hearing all that. So buckle up for that. That is really kind. Thank you very much. It's great to be on here, and congratulations on this podcast. I mean, just terrific. This is just wonderful to see it happening.
Oh, thank you. So, Dr. Armstrong, for those unfamiliar with the magnitude of this field, why are diabetic foot ulcers still one of the most underestimated complications?
Yeah, well, I think not to oversimplify all this stuff, but look, this is a silent and sinister syndrome, if you will. Kind of alliterative, but it happens to be true. Because what happens is folks with diabetes, they develop neuropathies. So they'll wear a hole in their foot, just like you, Gabby, or I'd wear a hole in a shoe or a sock, right? The hole, it's called a diabetic foot ulcer. And that happens now, as I think you know really well, every sector. around the world, and half of those get infected, and give or take 20% of those infections end up in hospital, which is why there's an amputation every 20 seconds, right? So some of those numbers, but every second that's an opportunity to make a difference, and we can back up the clock. And we think time's up for all this, but the reason it happens is because it's silent. So with, for instance, if someone were to get, God forbid, a heart attack, and drop dead, well, that's pretty loud, right? If someone were, God forbid, to have a stroke, right, or to get cancer, these sorts of things, we all know how serious these problems are. But these problems at the end of the body that are often just covered up by a shoe and a sock, that have no feedback, painful feedback. You're going to behave differently if you're a person with diabetes that has one of these things. It's not going to seem that important to you. And it's not a problem that you have. We just have to do a better job of working with the patients to get them to understand that pain, as one of my great mentors, Paul Brand, used to say, pain's a gift, right? And it's a gift that no one wants, but it tells you when there's problems. And we have to sort of re-gift that gift back to patients by telling them about it and telling society about it.
Oh, wow. Thank you. So you spent decades trying to prevent amputations around the world. Was there a specific patient or a moment early in your career that changed your entire mission?
Yeah. Wow. Okay. Well, well, that's a great question. So there's so many patients, but there is, when I was a resident, my first day, or technically my second day as a resident, my first day in clinic as a resident. So there were actually two patients. So the first patient was this guy that was a 6'8" college basketball player, and he had just uh, fractured his foot, and we were putting in a big screw in his foot. And I had just done that. It felt really amazing. It was testosterone inducing. You get a chance to really help this guy. And you thought, wow, that's awesome. So I thought I would go and help out in clinic, and I'd bring this guy. He spent the night in the hospital, and we brought him over to the clinic. We were going to change his dressing and send him home with his family. And so we see this big guy, 6'8", just kind of flowing over the chair, and he's just in so much pain, crying in pain, as you might, right? As you should after surgery. But, and I'm feeling bad for the guy, and I'm thinking, how can I help him? But as they're taking off his dressing in that room, I figured I'd help out in clinic because he was busy. And right next door, there was this lady that was like, maybe, I don't know, she was maybe 4'9", 4'10". So, and she was Indian. She was South Asian. Literally just came in from India to be with her family. And in this little treatment room, there's like 4 people in the room, in addition to her, including her oldest son, who was kind of translating from Hindi. And it turns out that, she had like a wound on her foot, and she had diabetes. But interestingly, also she had leprosy. So she had both leprosy and diabetes. And leprosy also can give you neuropathy. And
Mhm.
but I was treating her on this wound on the bottom of her foot, and while they were taking off the dressing, we were going to put a cast on the other guy. And so I figured, well, I'll debride this wound, clean it up. And as I'm cleaning her up and debriding her, surgically, she's bleeding on the floor, and I'm holding pressure and everything, and I'm looking at her, and she's just not reacting at all. And I'm hearing this guy screaming next door in pain, like, as they're putting that thing on. And so then I, put the dressing on her, and she was just as gentle as could be. And I looked up at her hands, and I noticed her fingers were burned. And I thought, what the heck? And so I asked her son what's going on there. And he said, well, she loves to cook for the family. And she was making, when she got home, she was, she made some naan bread, some bread, and she was putting that in the oven, flipping it over. And she couldn't feel it because of her neuropathy from her leprosy. And I was just like, so then I'm like stepping back, and I'm seeing, and I could step back, and this was kind of on a corner, and I could see both treatment rooms, and I could see both patients. And I see this guy, giant of a man, great guy, but crying, like we all would, like a baby, right, in one room. And then this woman, literally half his size, but peaceful as can be, bleeding on the floor with her fingers burned half off, and with just no reaction. I thought, man, eeny, meeny, miny, mo. I'm thinking we're taught to respond to pain as clinicians, as doctors, as nurses, right? But we're not taught how to respond to the absence of pain, and how do you do that? And so that was it. That was like the second day, and so anyway, that is a story. There you go. You can run with that one.
Wow, that was an incredible story.
It happens to be, yeah, it happens to be true. So there you go. So it's, yeah, that's a good one. So there, I still remember it to this day. There are a lot of others, but that one definitely influenced me.
Wow, thank you. So, Dr. Armstrong, you hold MD, a DPM,
Yeah.
PhD, and everything more. How does it shape your approach to limb salvage?
I always tell our trainees that, your degrees and all that stuff,
Mhm,
all that and your training, that should, I guess I always say it should define you, meaning it should tell you like, who's your mentor, where you trained, et cetera, et cetera. But those things shouldn't confine you, right? And I know that sounds like I'm just playing with words there, but I'm not. In other words, look, you might be a foot doctor, you might be a dentist, you might be a neurosurgeon or a plastic surgeon or a GP or a physical therapy for a physical therapist or occupational therapist. It doesn't really matter if you're interested in something, especially if you're at a university, but even if you're not, I mean, it's just the world's your oyster. You could go out and try to make a difference in that other thing. And all the stuff that you've done to this day to get you wherever you are prepares you to like jump out and do something a little bit different. And so, I think you were saying in the intro, I mean, I'm a foot doctor. I'm like a toe mechanic, but I have a cross appointment in neurosurgery, right? And you'd say, what the heck? But that's because I have an interest in it. It's not because I just have an interest and I have friends, my buddies in, doing work in brain computer interfaces and all kinds of really super cool, exoskeletons and stuff. And I have spinal interventions and things of that. So why should it confine me? Is there some weird Mason-Dixon line or Maginot line or something that the ankle that should stop me from collaborating? Or if you're a nurse, why not get into this as well? And it happens and you see it. So that's what I mean.
mhm,
These degrees, they're great and you can go out and do all that stuff. But the only reason I got all these extra degrees was frankly because I just wanted to spend some time with mentors of mine and kind of honor them and kind of pay it forward. That was it. But I'm a foot doctor. I'm a podiatrist. The DPM, that's my first degree. It's for sure my most important degree.
Oh, wow. So,
But
Dr.
all, but I'll just say all of them are important, but they're important so they can get you to see people and look after people, right? With a license and things, but they're not important. In other words, my point is you can be like evangelical about the problem, but I guess you could be agnostic about the different specialty. Or, it doesn't matter if you're a nurse, you're a physical therapist, you're a podiatrist, you're an orthopedist, you're a plastic surgeon. It doesn't matter what you are. As long as you have an interest in the problem, that's what matters. And then it's your ability, right? It's your
Mhm.
training, it's your ability that should allow you to go out and look after people.
Yes. So, Dr. Armstrong, why do diabetic foot ulcers recur so often, even
Hmm.
after they appear healed?
Yeah. So that's the other thing. It's like every other you were mentioning, talking about remission and that term. And it's really important to understand that just like any other chronic disease, I think it's kind of the height of hubris to think that we can heal anyone. And so what do I mean by that? Well, look, if you close someone up in the operating room, right? Oh, that's wonderful. Feels great. And if or you might be able to heal someone in clinic and see them epithelialize. But that's just the beginning, right? After all this stuff, I always tell my trainees that nothing ruins a good surgical result like follow up. either, either, right? Either the patient's going to go down, meaning they're going to die or meaning they're going to pass away. And hopefully they do that at home with their family and not hooked up to all kinds of other stuff. Or your repair is going to go down. One of those two. And the goal is for you as the clinician or as the team to be there when that happens. And so you can make that recurrence as uncommon and as uncomplicated as possible. That's the big idea. And so just like with cancer, you know, someone enters remission by whatever measure you might have. It's the same idea with diabetic foot ulcers and with other wounds as well. We use the word remission, and the same thing plays for not just on the toe side, but on the flow side, on the ischemia side, because there are more re-interventions around the world, endovascularly and open, than there are vascular interventions, and so it's ridiculous or just I think naive to think if you're a surgeon that you can that procedure that you're going to do is the end all and be all. Once you touch someone, you got to treat them and you've got to look after them, and that's really, really important. So that's the big idea of remission, because 40% of these wounds are going to recur at 1 year, 2/3 at 3/4, give or take at 5. And so you want to be there when that happens, and there's all kinds of cool things that we have available now to extend those, what we call ulcer-free days now. And it is like the most fun time ever to be a foot doctor or to be interested in this area, because there's all this stuff happening now.
That's so true. Thank you. I like ulcer-free days. I think that's
Yeah.
really cool. So
Yeah.
in your opinion, what is the single most overlooked factor that leads to amputation?
Yeah. I think the single most important factor is just these folks. Well, I'll give one, but there's multiple. But I would say, uh, if a patient were just they've got to knock their socks off when they go in for their primary care visit. But them not getting annual exams by their foot doctor or by their general doctor is really, really is completely underdone, underutilized. So getting that screening, I think theoretically we could prevent almost every complication if we could get out in front of these things. So that could happen a whole lot more. And the cool thing is you could do that rapidly now. And and for a GP, for a family doc or a podiatrist, they don't even have to do some of these things. Although ideally we'd like them to do this. Some of this could be done by a nurse or even by family members now, to see if someone has neuropathy or if they have problems circulation wise, or if they have something on their foot that won't heal or something that looks funny. And so that big idea, I think that's the single most important thing. If we can get out in front of all of that, after that, I would say the next most important thing is developing teams. And, just like you have a cancer team, just like you have a stroke and rapid response team for MIs, for heart attacks, same thing for feet. And for just like a cancer analogy, just like a cardiovascular analogy, these teams that are interdisciplinary really, really make a difference. I mean, the data now are compelling around the world, not just in the US, not just in North America, but around the world. If you put that team together, then there is, on average, 60% relative risk reduction for amputation then compared to when you've put it together before. And get this, it not only prolongs legs, it prolongs life. There's just data from Singapore, from a podiatry unit being set up there along with vascular unit, but adding the podiatry unit seems to have a relative risk reduction for mortality. So it's just these simple things, because you're getting out in front of things before they happen. And that has a profound upstream effect. You start at the toe, you work your way proximally.
Yes. So, Dr. Armstrong, what's one question about diabetic foot disease that medicine still hasn't answered as yet?
Yeah. Okay. Well, there's a lot, but I'll just give you one top of mind. I don't think that we've identified or classified infection really well.
Mhm,
Especially like mild infection, I think it's right now we say it's two kind of like two or more signs of inflammation plus something like pus or something or other. But that I think we have to do way better because I think sometimes people are over treating people a lot of times with antibiotics
mhm,
with that. But I think also there might be people that need to be aggressively treated either hyper locally with a really good quality debridement, getting all that bacteria out of there, getting all that those senescent cells and inflammatory chemokines and cytokines out of there, kind of a control alt delete. I
mhm,
think that is not done well enough because we don't have a good diagnostic or theranostic yet. Some of these things are emerging. There's obviously some imaging where you can transilluminate the bacteria in wounds. That's been happening now for many years. There are really cool bedside and chairside diagnostics. We've been working on, no kidding, electronic noses, looking at volatile organic compounds, VOCs, just like you get you get scanned at the airport. If anyone's ever swabbed like an area, have you ever seen that? They're looking for
mhm.
VOCs for explosives. Same thing for infection. So that's cool. But there's all kinds of other really cool tools and also tools that we can have in the laboratory or rapidly bring to the chair side or even to the home or even to the little bandages we put on that could probably identify this. But right now, that's a big unmet need. I know it sounds like I'm getting really hyper focused on that, but that would be really cool to be able to do, to be able to measure.
Okay. Wow. Yeah. So you've worked internationally for years. What's the biggest difference you've seen globally in diabetic limb salvage?
Yeah, this has been, look, thanks, Gabby. That's a great question. I would say that the when I first got started, 3 decades ago, maybe in this, there these teams in units around the world where you have interdisciplinary teams of, toe doctors and flow doctors and others, endocrinologists and diabetologists and other surgeons working, all of those things and nurses, all of those things were really exotic. Now, now that is getting way less so. I'll give you an example. We just started during the pandemic. I mean, this is only a few years ago already. We started something called the American Limb Preservation Society. This is like a not-for-profit, and it has American in there, but it's really a multinational. But the goal with ALPS, the American Limb Preservation Society, is to bring. We call it the joke. I call it. I say it's like a cross between a dating app and a marriage counselor
Oh,
for
wow.
folks for folks who want to put teams together, right? And so that thing now, so that just started again during the pandemic. It already has like more than 2,000 members, and it's unbelievable. And that has spread to a bunch of countries already, and so you see that now, and you see there are health ministries now in countries around the world, obviously the U.S. too, but start that are now taking this on, trying to develop models and teams from the top down, as well as necessarily for people like us chatting in our own individual clinics from the bottom up. But both of those are happening now, and I tell you what, Gabby, that is life affirming.
Mhm. Oh, wow. So, Dr. Armstrong, do you believe we're entering an era where wearable technology can predict ulcers before they even happen?
Yeah. Oh, yes. That's happening now. In fact,
Yeah.
I'm not joking. I just got, you're going to think I'm making this joke. I am not. On my phone, I think I saw already an alert. I got to look after we chat, but it's from something that just takes a picture of the bottom of the foot. we call it a foot selfie. That's a joke, but there are scales, there are smart scales that will then alert me, the clinician and the nurse. It was just the nurse, the doctor, and the patient of something that's worrisome on the bottom of the foot, and then and not a day goes by where I don't see something like that now, stopping a hospitalization, stopping a wound, or someone stepping on something. And so that I got to look right after I talk to you, but that just happened now. But there's like smart scales, as I mentioned. There are
Mm-hmm.
smart bath mats. There are smart. We're starting a big study using smart insoles that's funded by the National Institutes of Health. That's a study called Wired Up, where we're randomizing people into good quality shoes or good quality shoes and insoles, or good quality insoles and shoes that are made smart that can alert for hot spots and high pressure areas. So these things are happening now, and smart socks have been around now for the last decade, and now they're getting very real, and the data are just compelling. So it's these things now are becoming consumer electronics, and that merger of consumer electronics, consumer gadgets, and medical devices is real, and it's happening now. And it's just, that is another thing that is really, really exciting.
Wow. So, Dr. Armstrong, how can smaller countries or underserved communities improve diabetic foot outcomes even with limited resources?
Yeah. Again, this is easy, Gabby, to talk about podcast, and it's hard to do in real life. But just because it's hard doesn't mean it's not fun. And just because it's hard doesn't mean, right? And just because it's hard doesn't mean it's not worth a life's work. And there are women and men that have done this all over the world, from Africa to South Asia to Indonesia to Australasia and everywhere else in between. So you see these sorts of things where hyper local care in under resourced, as it were, settings can make a difference. But you know what makes the difference? It's like always, it's not technology, it's people.
Mm-hmm.
And you see someone that she might want to start, she might be a podiatrist and she might want to start a clinic in, let's say, Soweto, South Africa. This is a real person. I'm just giving you as an example, but you can name anywhere else. And then she goes and gets her buddy, who is a plastic surgeon, and then also a vascular surgeon. And then all of a sudden they have a unit, and, and that sort of thing gets multiplied and then suddenly becomes a whole nationwide movement, as it were. And so you start to see that happening in one clinic, in one hallway, and then it expands from there. That's how, I mean, God knows that's how we did it. I'll give you,
Mm-hmm.
I've done this now a lot of times, and I can name all of my, I'm the luckiest foot doctor on the planet. I've had some of the best friends and mentors and partners over the years. But as an example, with my I call him my Flomigo. We have all these terms, Flomigo Prime, and that's Joe Mills. And Joe and I in Arizona many years ago now, we were literally the two of us. We did this entirely bottom up. I mean, look, I was recruited out to U of A, University of Arizona at the time, but that was it. Just that there were no other resources like staff or anything else. But Joe and I just literally had basically a hallway, half of a hallway, and we had tow rooms and flow rooms, and the two of us were just fighting like amongst each other, and our patients just would love it because they thought, oh, these guys, but the medical students, they thought, my God, these guys are, you guys are going to kill each other. But he and we even had like a Mason Dixon line for our paperwork and everything. But we banged into each other. It was these forced curbside consults, and that was hard. And it was, but it was, and it was unnatural to have. I'm serious. I mean, everyone talks about team, but inherently these interdisciplinary teams are not natural. It's not because, you have these hyper local, everyone has their own, kind of tribal kind of specialty.
Mm-hmm.
And so everyone gets all kind of worked up by that stuff, by their scope, and like, what are you supposed to do? Hey, trauma is supposed to do that. Vascular is supposed to do this. IR, cards, whatever on the flow side and all the other things. That's all baloney. But when you get into a unit that's interdisciplinary, you just see that these guys, her, she, him, there. It's just about that. If you care about the problem, doesn't matter if you're a nurse, a doc, therapist. So this is what we did, and it was just the two of us. And then the two of us all of a sudden started to get really busy, and we started to bring in other folks. We brought in someone from the prosthetic and orthotic company to be full time in the clinic. Then we brought in nurses and other surgeon specialties and physician specialties in that clinic, and all of a sudden this crazy hallway is just bustling with people, and everyone's like bumping into each other. It's like a bunch of it's kind of a bunch of pachinko balls kind of like hitting each other, but it was awesome and hard and unnatural and less efficient on the day-to-day end, but way more effective and efficient on the money end, on the whatever, all the downstream stuff that happened. And so you start to see this happening, and you could do this yourself, right? It starts with one person, and then phone a friend, find a friend. We always call it find your BFFF, your best foot friend forever. And that's like you could do that, and that's part of what made Alps, because we just wanted to make it to where you can like you do you do your own thing, because every place is a little different. Every place has their own individual accent. Even different clinics that are just one is in the same zip code as the other. It's just down the street. Everything is a little different. But there's some basic things that you start with. And you start, Gabby, with caring. And you
Mhm.
really care about the problem. And then you get in there and you do the work, and you find a friend, because this stuff, you start doing stuff and people start to say, hey, what's that happy podiatrist having all that fun there, bouncing around all those, seems like that's fun. And then all of a sudden it becomes kind of addictive, and you start to see. And so this is it. That's the idea. That's the blessing of this whole thing, the whole enchilada.
I love that. So when the history of diabetic
Mm,
foot medicine is written decades from now, what
yeah.
chapter do you think we're living in currently?
Oh, yeah. I think we're kind of in the end of the middle, because I think we're at a point now where we're starting to see these teams start to develop, and we're starting to see the technology marry with the teams. And just like you were asking, and I think in the arc of time now, we're going to start, especially now as we're trying to treat these patients better medically. I think we're going to start to see this problem become less and less common. And even though right now there's a lot more wounds showing up, it's because we're identifying more people with diabetes and they're living longer. And that living longer is good, but we just
Mhm,
have to identify all these things. So I think that's where we are right now. But we got a ways to go. But
mhm,
I tell you what, it's really exciting because, I'm my dad was a foot doctor. He passed away really young at 71, like 20 some years ago, but
okay,
smartest guy I ever knew. But, we have three girls, Tanya and I, and our oldest is a third generation foot doctor. And and her boss is my old fellow from 20 years ago, her former
wow.
boss at UT. Now she's starting a fellowship at Hopkins and limb preservation. But you see that, and you see the next gen, and these women, these men, they're all going out there to make a difference and to pay it forward. And that's the big idea. And so that's whatever chapter is written. Maybe it's just an endless scroll. Maybe it's not but you know what? Maybe it's not a doom scroll. Maybe it's the opposite of a doom scroll, right? Maybe this is the kind that ends up in a better place where our patients are, moving through the world a little better.
I love that, Dr. Armstrong. So, do you think we'll ever reach a future where most diabetic related amputations become rare or non existent?
Yes, absolutely. Yes, I absolutely see that.
Okay, let's hope. And if every clinician listening today remembered one thing about diabetic foot ulcers, what do you want them to remember?
I think just if for clinicians, I would say, look, team up, find a friend. And I would say that as the advice, because you can't do it alone, like with any
Mhm.
chronic disease. And if you think you could do it alone, then that's I wouldn't say you're wrong very often, but in that case, I'd say you're wrong. This takes a team, and no matter what your skill set, you could always do a little bit better, and always add to it. And when you team up, again, it's harder than what you're doing right now. But just like I said, just because it's harder doesn't mean it's not fun, and doesn't mean it's not more fun. And when you start to do that, you start to see the how life affirming this all can be.
I love that. So we're entering into our rapid fire. This is like the end of it.
Oh
So
boy,
these are like first response
yeah,
answers. So
yeah.
what do you think is the biggest myth about diabetic foot ulcers?
I think awareness.
Wow. Thank you. No, you're so right. So if every clinician can improve one skill tomorrow, what would it be?
I think phoning a friend.
Interdisciplinary. What paper or study are you most proud of? Because there's
Wow.
many. There's many.
I well, I don't even. That's a. There's no. I don't have one that I am more most proud of. Maybe the first manuscript, because I'll tell you, I know this is rapid fire, but back in the day, we would get these papers rejected in all the journals because not because of the quality at the time, but because of our like degrees, because they didn't know what a
Oh, wow.
podiatrist was. This is like 30 years ago. But then they saw we put the paper in without our degree. It would get reviewed, and then we would slap our name and degree on there afterwards. And they said, what can you do? So then that's how people were introduced, I think, to podiatry way back in the day, because they didn't. I mean, what do they know? But I'd say that kind of thing in making it more of a meritocracy. I'd say that's what I'm proud of. Not about any paper.
Hmm. What's an innovation in wound care that you're most excited about right now?
I think home-based monitoring.
Like the mats and things like that?
Yeah, all of them. I would put
Yeah.
them all. I'd mash them all up into one whole where we can monitor folks and measure what we manage while people are moving through the world. When they leave our clinic, they're only at our clinic for a fraction of the time during the day. The rest, the 99.9% of the time that they're outside of our unit, that now is we can have some feedback to the patients, and that is really exciting. And by the way, even some of the chatbots with our patients that they're having, where we're able to improve adherence now, which is really exciting.
If you had unlimited funding for one research project, what would it be?
Ooh, wow. I would put. Ooh, this is really hard. So let's talk about doing it and making a public health difference. We won't talk about answering a research question because we talked about that. So the answer to this is I would set up something where you could put teams in every metropolitan or every region of the world and set them up like a kind of, just like trauma centers, right? Level 1, level 2, and level 3. And every nation of the world, you said unlimited, and we could measure the before and after, and you measure the before and after effects of the limb preservation program. That's what I would do something like that, or even randomize people into something like that. But I think the before and after probably would be enough because you get a public health impact right away.
Wow. What's one piece of advice for residents entering limb salvage?
Yeah, find a mentor
Hmm.
or find multiple mentors.
That's definitely true. So outside of medicine, what keeps you inspired, Dr. Armstrong?
Oh, wow. Oh, we have three good girls, Tanya and I. I already told you about Alexandria. She's our oldest. The middle one did one of these Fulbrights in Greenland. Now she's at Hopkins doing PhDs and trying to how to get to yes or no in data centers. She's doing great. And then the little one, little Nina's in law school at Georgetown, but they're all
Oh,
doing great. So,
wow.
so that's number one. So that would be one. The other thing is gadgetry. I'm kind of a hyper early adopter of gadgets. I'm talking to you. Actually, I'm wandering around on a smart glass. We're talking to you on smart glasses. I'm sure it sounds good, but I don't even
Oh,
think about it
wow.
because
I
I know
didn't
it's
know.
great.
Yeah, fantastic.
Yeah, I know, but we were the first to use like Google Glass in the OR, and all this stuff but all kinds of other things like that. It was so I mowed lawns I'm not kidding, in the 70s to buy the first Timex Sinclair 1000, as I recall, for $200. Boy, I tell you, so that had exactly, I think, 1K of RAM. But it was
Wow.
like crazy. And we hooked up to the TV. That was before we even had I just had a Pong thing for $200 as well, but and I didn't even have an Atari yet. But so I've been a kind of gadgeteer forever, and so I've always, in addition to being a foot doctor, that's definitely something that's of interest.
So thank you. This is the last one. Finish this sentence. The future of limb preservation depends on.
You.
Oh, thanks. Thank you. Oh gosh. Okay, so as we wrap up today's episode, I want to extend a sincere gratitude to Dr. David Armstrong for not only sharing his expertise, but also sharing his passion for changing the future of diabetic limb preservation. And to every healthcare professional or even patient listening out there, decisions you make today can determine whether a patient walks tomorrow. And thank you so much again, Dr. Armstrong.
Oh, Gabby, are you kidding? This was super fun.
Yay! I'm so happy. And this has been LIMBWatch, and take care of your feet because they take care of you.